Good morning. This is my condition presentation on delirium for Social Work 502. This is James West. Introduction. Delirium. We're going to talk about that, the definition, the types of delirium, which include commonality, the seriousness of it, the prevention aspects. We're going to go over the signs, symptoms, causes, risk factors, complications, and then finally the diagnosis of through the DSM-5. Delirium, by definition, sudden and severe change in brain function that causes a person to appear confused or disoriented or to have difficulties maintaining focus, thinking clearly, and remembering recent events, typically with a fluctuating course. Delirium can be triggered by a serious medical illness such as an infection, certain medications, and other causes such as drug withdrawal or intoxication. Um, Older patients over 65 are at highest risk for developing delirium. People with previous brain disease or brain damage are also at risk. Some patients become agitated while others become types of delirium. Hyperactive delirium, probably the most easily recognized type. This may include restlessness, for example, pacing, agitation, rapid mood changes, or hallucinations, and refusal to cooperate with care. Hypoactive delirium. This may include inactivity or reduced motor activity, sluggishness, abnormal drowsiness, or seeming to be in a daze. Mixed delirium. This includes both hyperactive and hypoactive signs and symptoms. The person may quickly switch back and forth from hyperactive to hypoactive states. Commonality, seriousness, and prevention. Commonality. Delirium occurs in up to 25% hospitalized patients, 50% of surgical patients, 20% of nursing home patients, 77% of burn patients, and 75% of ICU patients. An estimated 37% of surgical patients experience postoperative delirium. Delirium occurs in up to 50% of patients with dementia that require hospitalization. The serious aspect of it, seriousness. Its delirium is associated with many adverse outcomes, which includes increased mortality, falls, functional decline, cognitive impairment, and decline in significant cost. Delirium superimposed on dementia may accelerate the trajectory of decline and often results in long lengths of stay, readmissions, premature nursing home placements, or death. Delirium is a major financial burden to medical services and range from 38 to 152 billion per year. Prevention. Since frontline nurses are in direct contact with patients 24 hours a day, 7 days a week, RNs need to drive delirium prevention. The best prevention protocol simply consists of high level nursing care. Signs, symptoms, causes of delirium. Signs. Signs and symptoms of delirium usually begin over a few hours or a few days. They often fluctuate throughout the day, and there may be periods of no symptoms. Symptoms tend to be worse during the night when it's dark and things look less familiar. Primary signs and symptoms include reduced awareness of the environment, withdrawn, easily distracted, poor thinking skills, rambling, speech issues, disoriented, memory loss, behavioral changes, hallucinations, which include hallucinations, agitation, lethargic, making noises, withdrawn, and the emotional disturbances aspect could be depression, anxiety, fear, apathy, and personality changes. Some causes are certain medications, drug toxicity, alcohol or drug intoxication or withdrawal, stroke, heart attack, lung or liver disease, a fall, low sodium, low calcium, fever, infection, flu, pneumonia, and exposure to toxin. Risk factors and complications. Risk factors are being over 70, having anemia, functional disability, having surgery, opioids, antidepressants, hypnotic sleep aids, being a male, poor vision, and hearing. From ESKI 2019. Complications. Delirium may last only a few hours or as long as several weeks or months. If issues contributing to delirium are addressed, the recovery time is often shorter. People in better health are more likely to fully recover. Delirium in seriously ill people is also more likely to lead to one, a general decline in health, two, poor recovery from surgery, three, a need for institutional care, and four, increased risk of death. Diagnosis through its DSM-5. Diagnostic criteria as follows: A disturbance in attention, example, reduced ability to direct, focus, sustain, and shift attention and awareness, reduced orientation to the environment. B, the disturbance develops over a short period of time, usually hours to a few days, represents a change from baseline attention and awareness, and tends to fluctuate in severity during the course of the day. C, an additional disturbance in cognition, example, memory deficit, disorientation, language, visuospatial ability, or perception. D, the disturbance in criteria A and C are not better explained by another pre existing, established, or evolving neurocognitive disorder and do not occur in the context of a severely reduced level of arousal, such as coma. E, there is evidence from a history, physical examination, or laboratory findings that the disturbance is a direct physiological consequence of another medical condition, substance intoxication, or withdrawal, i.e., due to a drug of abuse or to a medication, or exposure to a toxin, or is due to multiple etiologies. American Psychiatric Association. Keep in mind, as you're diagnosing through the DSM 5, you need to specify whether substance intoxication, delirium, substance withdrawal delirium, whether it's medication induced delirium or delirium due to another medical condition, and delirium due to multiple etiologies. Specify if acute, lasting a few hours or days, persistent, lasting few weeks or months, or and identify all appropriate codes based on the severity or the specific condition. Resources provided. Thank you for your time.